I respectively call on Pharmacist Ibrahim Bello to give us the opening prayer. Thank you.
Okay, can we pray? As we are about to start this meeting, we call on God Almighty to come and be with us and guide us and bless our deliberation. Amen. End of prayer.
Amen. Thank you very much for the prayers. We pray that it be a successful meeting. I welcome everyone once again to Kwara State CPAN clinical meeting. Today's meeting promises to be very interesting and educative, as it is a real-life clinical practice experience. The presenter for today is pharmacist Raji Nafisat. She is the head HOD Pharmacy Department Civil Service Clinic, Ilorin. She will be presenting on diabetic emergency, hyperosmolar hyperglycemic syndrome. The presentation will be for 40 minutes, after which we'll have a question and answer session for 20 minutes before we end today's session. I urge us to listen attentively as she speaks. Questions can be sent via the chat box or by signifying to speak at the end of our presentation. Thank you very much. Pharmacist Nafisat, you may proceed. Pharmacist Nafisat, please unmute yourself.
Okay. All right. Okay. Good evening, everyone. I hope you can hear me clearly. I'd like to welcome everyone to this presentation. My name is Pharmacist Raji Nafisat, presenting on diabetic emergencies, specifically on hyperosmolar hyperglycemic state. Standing on existing protocols, I would like to once again welcome everyone. So as a way of introduction, hyperosmolar hyperglycemic state is one of two serious metabolic derangements that occur in patients with diabetes mellitus. It is normally characterized by hyperglycemia, hyperosmolarity, and dehydration without significant ketoacidosis. Most patients present with severe dehydration and focal or global neurologic deficits. Vital signs related to hyperosmolar hyperglycemic state include tachycardia. We have orthostatic decrease in blood pressure, hypotension, tachypnea, and hyperthermia when infection is present. Then physical exam findings and signs include altered mental state, confusion, lethargy, ill appearance, dry mucous membrane, sulking eyes are also present, decreased urine output, coma, amongst others. Then, according to a consensus statement published by the American Diabetes Association, diagnostic features may include the following: plasma glucose level of 600 milligram DL or higher, effective serum liter, profound dehydration up to an average of 9 liters, serum pH greater than 7.3, bicarbonate concentration greater than 15 milliequivalents per liter. Small ketonuria and low to absent ketonemia might be present. Then we have some alteration in consciousness. Imaging studies are also advised in this condition, and they include radiography of the chest and the abdomen. Normally, the chest radiograph is to exclude the presence of pneumonia. Then the abdominal radiograph is indicated if the patient has abdominal pain or vomiting. CT scan of the head is also indicated in patients with focal or global neurologic changes. ECG is indicated to exclude myocardial infarction and pulmonary embolism. The cerebrospinal fluid cell count, glucose, protein, and culture is indicated in patients with an acute alteration of consciousness and clinical features suggestive of possible CNS infection. Then treatment, according to the JMC8, consists of IV saline, correction of hypokalemia, and IV insulin. So once the glucose level reaches 250 to 300 milligram per dl, equivalent to 13.9 to 16.7 millimole per liter, dextrose should be added. Then the rate of infusion of IV fluids is adjusted, most times depending on the blood pressure, the cardiac status, and the balance between fluid input and output. Insulin is normally administered at 0.1 units per kg IV bolus, followed by 0.1 units per kg per hour infusion after the first liter of saline has been infused. Target plasma glucose is between 250 and 300 milligram per dl, equivalent to 13.9 to 16.7 millimole per liter. After recovery from the acute episode, patients are normally switched to adjusted doses of subcutaneous insulin. Then potassium replacement is similar to that in diabetic ketoacidosis. 40 milliequivalent per hour for serum potassium less than 3.3 millimole per liter, 20 to 30 milliequivalent per hour for serum potassium between 3.3 to 4.9 millimole per liter, and none is given for serum potassium greater or equal to 5 millimole per liter. So a case study to fully understand this state, the case review. So as seen on the slide, this is the patient demographic data. Her name is AH. She's 61 years of age. She's a female. She's a petty trader, married. Date of admission is the 18th of October, 2021. She's Yoruba in tribe. She's a Muslim. Islam is her religion. Then she resides in Ilorin, Kwara State. The subjective data was collected. So her chief complaint was generalized body weakness for 1 week, which has progressively worsened, severe enough that she cannot stand without support. So she was referred from a private hospital on account of that. And there was also alteration in consciousness of 1 day, characterized by poor response in conversation. But there was no preceding history of diarrhea or change in bowel habits, no vomiting, no fever, dysuria, frequency or urgency. History of osmotic symptoms could not be ascertained. No seizure, neck pain, or neck stiffness. Patient is not a previously non-diabetic. She just newly diagnosed, but has been a non-hypertensive diagnosed 4 years ago. She also has a history of diabetes in father and younger brother. The previous medications include the antihypertensive medications, which is Macnol, that contains amlodipine and ramiprile, 10 to 5 milligram. She was using tab moderatic and tab soprolol. Then objective data was also collected. When she was examined, she was found to be a middle-aged woman, conscious but confused, not pale, anicteric, non-febrile, no digital clubbing, no pedal edema. On admission, her pulse rate was 140 per minute. Her blood pressure was 132/92 millimeter mercury. Her respiratory rate was 24 cells per minute. And she was assessed to have diabetic emergency, likely hyperosmolar hyperglycaemic syndrome in a newly diagnosed type 2 diabetic mellitus patient. And according to the plan that was given to her, the investigations that should be carried out is the random blood sugar and fasting blood sugar, which is done daily, full lipid profile, HbA1c, urinalysis, urine MCS, and ECG. Then the medications she was placed on admission, 0.9% normal saline. She was to be given 1 liter every 6 hours. So this plays a vital role in maintaining proper fluid balance and keeping the tissues hydrated. Sodium is involved in cell processes such as muscle contraction, transmission of nerve impulses. Chloride ions are responsible for maintaining the acid and the base balance. Then she was also prescribed IV soluble insulin, 6 units every 4 hours. It's a recombinant rapid-acting insulin analog that facilitates passage of glucose, potassium, magnesium across cellular membranes. It also controls the storage and metabolism of carbohydrates and promotes conversion of glucose to glycogen in the liver. An antibiotic was also prescribed for her, IV Rocephin, 1 gram every 12 hours. She was also given XC, Clexane, and enoxaparin, 40 units daily. and this helps prevent and reduce thromboembolic complications, such as pulmonary embolism and ischemic cardiac complications. Antihypertensives also included bisoprolol, 5 milligram daily, which is a beta blocker. Then diuretic, 1 tablet daily, contains amiloride and hydrochlorothiazide, diuretics, just working by increasing the amount of urine that passes from the body. Okay. So this is the result of this is the result of the clinical investigations, the tests that are supposed to be carried out, the random blood sugar and the fasting blood sugar, and also the BP were measured daily from the 18th of October 2021 to the 26th of October 2021. So as can be seen from the table, the random blood sugar, the values of the random blood sugar were considerably high, and even the fasting blood sugar compared to the normal range of values that is supposed to be. So it's considerably high despite the fact that she was being on treatment. Then also our BP was a little bit high on the day of admission and has been fluctuating, but later balanced up during the course of taking the results. So this is the result of our EUCR, electrolytes, urine, and creatinine, and potassium being main ion that's supposed to be checked, that's supposed to be monitored, can be seen to be 3.2, which is within the normal range. And our full lipid profile was taken. HbA1c was seen to be high, that is 11.7% compared to the normal range of between 4.6 to 6.2%. For our urinalysis, glucose and ketones were seen to be positive. Bilirubin, protein, urobilinogen, and nitrate were negative. Specific gravity of 1.015, pH of 5, and we have trace amounts of blood in the urine. So as explained earlier, the RBS was not going to the values that the prescribers wanted or the doctors wanted. So on the 20th of October, Lantus 10 IU was included in our medication. There were no significant changes. On the 21st of October, the soluble insulin that was given 6 units was increased to 8 units 4 hourly. Lantus was increased to 16 units. Bisoprolol and Diabetic were discontinued. Now we have telmisartan 160 milligram daily and atorvastatin 20 milligram included to the treatment plan. Then on the 25th of October, the dose of the soluble insulin was again increased to 10 units every 4 hours, then Lantus to 20 units daily. But still, the result was not satisfactory. So on the 26th of October 2021, both soluble insulin and Lantus were discontinued. Then metformin 1 gram twice daily and mixed insulin 26 units in the morning and 40 units in the evening were included into her plan. So this is just like the pharmacotherapy of our updated medications. Lantus insulin, although was discontinued, is a long-acting man-made version of human insulin, and it works by replacing the insulin, excuse me, that is normally produced by the body, and by helping to move sugar from the blood into the other body tissues where it is used for energy. Then mixed insulin that has become the mainstay of treatment was helped by getting the blood sugar, that is glucose, into the cells so the body can use it for energy. It can be used alone or with other oral anti-diabetic drugs such as metformin, as seen in this case. Metformin was added to her treatment plan. Metformin is a biguanide agent. It lowers both basal and postprandial plasma glucose, and it works by inhibiting the production of hepatic glucose, thereby reducing intestinal glucose absorption and improving glucose uptake and utilization. Then telmisartan, the antihypertensive use, that is ARB, it works by blocking the vasoconstrictor and aldosterone secretory effects of angiotensin 2. Atorvastatin, which is a class of medications called HMG-CoA reductase inhibitors, works by slowing the production of cholesterol in the body to decrease the amount of cholesterol that may build up on the walls of the arteries and block blood flow to the heart, brain, and other parts of the body. So the drug therapy problems found in this case study is first of all non-adherence. The patient had a history of non-adherence because even on admission, there was a slightly high blood pressure on admission. And during admission, the patient was seen not having most of the medications like the insulin. And most times on investigation, it was found that because of maybe economic conditions, but the patient was still encouraged to try and get her medications to make it regular. So even despite treatment, her blood sugar was not still going to the normal range of values. So the patient was not regular on.
We can't hear you again, almost in a FISAT. We lost your audio. Almost in a FISAT. Almost Rihanna, can you find out what is wrong with her? Almost Rihanna.
All right, sir. All right, sir. I will do that, sir. Okay.
Then,
okay, she has a network issue. Okay.
I think she's trying to
connect.
she's talking. Yeah.
Wait, she's not more on the call, she has been turned off.
Let me call her to inform her about this.
Okay. 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 She's back now. She can go ahead and unmute herself. She's back.
Okay, sir.
Just ask her to unmute herself and continue.
Okay.
Almost in a FISAT, you can unmute yourself.
okay.
Okay.
Okay, so
We're not hearing you. We're not hearing you. We are not hearing you.
Pharmacist Nafisat, can you hear us?
We're not hearing you again.
We can hear you. Sorry for that. Let me get through to her. Okay. Hello, everyone. Sorry for that. I'll get you to her. Guess it's the network.
I can hear now.
Fam, can you hand it and start again?
Okay. Administered. Then also you have an issue of one drug. Beta blockers and diuretics are not the drug of choice in hypertensive patients comorbid to diabetes. According to GNC 8, we have angiotensin enzyme inhibitors or angiotensin receptor blockers. They are the drug of choice for such patients. So for patients that are hypertensive and also diabetic, the first drug of choice are normally ACEIs and ARBs. And it was seen that the drugs were changed, and she was given telmisartan 180 milligrams for antihypertension. And from the results seen in clinical investigations, the blood pressure was normal. And also, there are also some drug-drug interactions that can occur, although not serious, but drugs should also be administered with caution and strict monitoring. Cetrazone, which was the antibiotic that was used for the patient, increases the effects of the enoxaparin by anticoagulation. We have bisoprolol and modretic, which both affect the concentration of serum potassium. So the potassium level is important that should be monitored from time to time. Then telmisartan also increases the toxicity of atorvastatin. Telmisartan and metformin both increases the effect of insulin. Telmisartan increases the effect of insulin by unspecified interaction mechanism, while metformin does that by thermodynamic synergism, which is really important for the patient. But still, the blood sugar should be monitored to avoid an episode of hypoglycemia. Then also enoxaparin increases the toxicity of telmisartan. So the goals that want to be achieved in this patient is to ensure that the patient understands the importance of strictly adhering to medications prescribed, and also to prevent occurrence of any adverse events that might occur with drugs administered. Then the pharmaceutical care plan for the patient is patient education. The patient and the caregiver was educated on the importance of adherence, maintaining a proper diet, and regular clinic visits to prevent frequent hospitalization and improve quality of life, and also to prevent the long hospital stay. If the patient is adherent to his drug visits, then interprofessional interaction to concerns on possible drug interactions was communicated to the chief nursing officer, as they are in charge of taking care of the patients and giving medications, and assurance was given on steps to be taken to prevent such. So these are my references. Thanks for listening.
The moderator, can you take over for that?
Okay. Well, sorry, she's trying to log in again, so she'll be joining us shortly. Okay, yeah, so that was an amazing presentation. If you are just joining us, the speaker presented on diabetic emergency, hyperosmolar hyperglycemic syndrome, using a case study of a patient she had So the floor is now open for our questions, comments, and other additions. I'm sure the presenter will be joining us very soon. Thank you very much. So questions, any questions, comments, observations, anything we'd like to hear? Okay, she's back with us now. Can she continue from where she left off? Pharmacist Nafisat, can you hear us?
I said, next, it's time for questions and contribution. Okay. So we have played the recorded video. I think that's the end of the presentation.
Okay.
So it's just time for comments and contributions from participants. Okay.
Comments, questions, and other additions, please. Okay. Pharmacist Biokusa, please start.
Hello, good evening.
Good evening,
sir.
That was a very wonderful presentation. And let's appreciate the presenter for the thorough job done. I just want to make some comments, not question really, that most prescribers, there's a need for them to work with pharmacists so as to prevent all these medication errors. We have found out that most diuretics now raise blood sugars. In fact, we've gotten issues where a supposed diabetic patient on withdrawal of just hydrochlorothiazide and some other diuretics, they go back to normal and the case is reversed. So I think there's a need for medical team to come together, as I keep advocating, so that all these medical errors could be prevented. Secondly, there's a big error in introduction of these statins. Studies have found out that when you start statins, you don't stop. It's like taking a medication for weight loss because the number of cells in you remain the same. So once you stop taking the drug, you go back to the normal weight. The same thing happens to the issue of statin being used to lower the lipid level, particularly the low density cholesterol. So I think it's good for us, those of us in this clinical setting, to always advise doctors. So you would only start statins when it is extremely necessary. And when you do, I think the patient has to continue for life. Thank you very much.
Thank you very much, sir, for your contribution. Pharmacy, the next person.
All right, thank you. It's Dr. Oli.
Oh, okay, sir.
Yeah.
Thank you for joining us, sir.
Yeah, thank you. It's a pleasure. So I want to thank Pharmacist Nafisat for that presentation. I'll ask one question, then I will make some comments. Pharmacist Nafisat, if you're hearing me, when you started the presentation, you gave us an overview of what a hyperosmolar hyperosmotic state is, and you told us how it is managed. And the process, you told us the number of tests that should be carried out. Like I saw ECG, CT scan, and the other tests. I want to ask, were these tests all carried out for the patient? That's my question. Then my comment generally. When we are dealing with diabetic patients, pharmacists have a lot of job to do to help the diabetic patient. From what I can gather in the presentation, this patient is a newly diagnosed patient and she has run into complications before a diagnosis. So this patient needs more than just counseling, she needs to be thoroughly educated about the disease, coupled with the fact that she's now having two dangerous comorbidities that impinges on the kidney and the heart. Hypertension is a risk factor for kidney disease, is a risk factor for heart disease. So is diabetes. They are both, you now have two risk factors for heart disease and kidney disease. So the extra attention needs to be paid to those patients and help them to get it right in the point of treatment. That's my first comment. My second comment will be on the second drug therapy problem, wrong drug, where the patient was given bisoprolol and Diabetic. Now, I understood from the presentation that this patient was first hypertensive, and then she later then developed diabetes, which was diagnosed later in the hospital. So it may not be totally correct to say that the bisoprolol given was wrong and the Diabetic, because if she has also run into complications arising from hypertension, she may be having heart diseases, like, for example, ischemic heart disease or even arrhythmia, that will necessitate the use of bisoprolol in this patient. And in the case study, I did not see that ECG was done for this patient. So it was wrong also to just have withdrawn the bisoprolol without carrying out ECG for this patient to rule out ischemic heart disease or arrhythmia before withdrawing the bisoprolol. So even though temistatan is indicated for the patient, it could have been an add-on, because if this patient has heart diseases, then she's going to come back to the hospital in a short time, because she's now having another risk factor for heart disease, and the heart disease is not being properly taken care of by withdrawing bisoprolol. So before the bisoprolol was withdrawn, that the Diabetic may be correct to have been withdrawn, but the bisoprolol, there was need to establish that this patient does not really require it. And the only way to have established that was to either have the previous record that led to the use of that bisoprolol, or an ECG carried out on this patient and some other tests to rule out cardiac diseases. All right. Then the final comment I want to make is that as clinical pharmacists, pharmaceutical care, the goal for the patient is part of pharmaceutical care. It is not outside pharmaceutical care. It's where you start the pharmaceutical care, you state the drug therapy problem, then the problem you identify, you now set goals, which are the ways you're going to deal with the problem, and then you follow on with objectives, the process to follow to achieve those goals, and then you need to also do a follow-up on the patient, which we did not see particularly in this presentation. So next time as pharmacists, we must, clinical pharmacists, we should make sure that we put those elements there, but because those are core practices. Thank you.
Thank you very much for your valuable contributions. Pharmacist Nafisat, can you answer his question, please? No, we can't hear you, pharmacist.
Maybe she has not unmuted herself.
I think she has a challenge with a device. So
Yeah.
she's just speaking to herself. It's better you use your phone.
Please, one more thing, please. Before she comes on.
Okay, sir.
Yes, sir. So on the comments fellow Bioko. So I just want to say that this patient on 13, this patient actually needs the 13 because the patient in the lipid profile, there was the low LDL is bad, but she even has more triglycerides. Triglycerides are one of the, risk factors for heart disease, and it was very high in this patient. So this patient has particularly 3 risk factors. One of them is hypertension, the other one, diabetes, and then she now has high triglycerides. That was why they used atorvastatin specifically, because atorvastatin can help to correct
Yeah,
Thank
hello,
you, sir.
doctor. Yeah, sorry, can I make a comment too? Just simply, I think there's a need for us to check. I'm not into clinical practice, but I think I take time to read quite a lot.
I hope we had this.
Hello, are you hearing me?
Yes, sir, we can hear you, sir.
Hello?
Yes, I was just trying to make my comment, especially in the area of use of
Can we hear
statins.
me?
People take statins for a very short time, and it doesn't really help. That is my comment. So you can do a check on how to use statins. People take it 6, the doctor will just recommend 2, 3 weeks, 4 weeks. It doesn't solve the problem. The patient quickly go back, particularly this particular patient with the lipid profile we've seen here, and then the response, the response to the treatment. You see, over a week, the FBS and random didn't fall as expected. When you look at that chart, that result, the FBS did not really fall as expected, despite the fact they were using drug. So the likely problem this patient has is high, what do you call it, high glycemic index. I didn't even see the result there. Maybe he has a high glycated hemoglobin. Let me use that's what I want to use. He might be having a very high glycated hemoglobin, which is a serious problem for hypertension patients, because the oxygen, the blood, the hemoglobin now carries glucose instead of carrying oxygen, which is dangerous, and that is why we seem to be having some kidney issues and then some other organs. And if you check this particular patient, the contractibility of the heart will be reduced.
Yes, sir. Can you
Unfortunately,
hear us?
unfortunately, like you rightly said, the ECG was not done, and probably even the echo was supposed to have been done. But all the same, there's a need for healthcare team to work together so that we can cross-check our recommendations and results, and then work together for the betterment of the patient. Thank you very much.
Thank you, sir. Pharmacist Nafisat, can you hear us now?
I think if she has problem with her device, we don't need to bother her.
Okay.
Can you call her behind the scene to remove the earpiece?
Okay, sir. I will do that, sir.
Let her remove the earpiece.
So pharmacist Renat, I think we should excuse her and let us move towards ending the meeting. So was he has challenges, I think, on the what I'm looking at now.
Oh, okay, sir.
Let's go ahead to round up.
Okay, do we still have any comments or questions? We can have the questions I will ask and she'll reply to them. Can put it on the platform later. Any more questions or contributions before we round up for today? Okay. Thank you everyone for joining us. I hope we enjoyed today's presentation and we have learned one or two things.
Except for the technology issue.
Yes.
Sorry about that, sir.
No problem.
Yes, sir. I wish everyone a good night's rest. Thank you, Maz and Sas.
Thank you.
All right, good night.
Good night.